bradyarrhythmias occurring in a person. So the objective at this particular point, the way we stand at this particular point is we have learned the roadmap for the first 15 seconds of analyzing a ECG, the heart rate, the axis, and the period duration, and check out whether P is followed by a Qrs complex or not. And next, I'm going to talk to you regarding short PR interval conditions versus a broad PR or rather a wide PR interval or a prolonged PR interval conditions. The next condition that I'll be explaining to you will be having a short PR interval. Let us understand why. You see, the current always goes from SA node to AV node, goes across the two sides of the AV node, but AV node exhibits a very slow conduction. That is why in physiology you will read always the word written AV nodal delay. In fact, I would like to highlight that about 0.1 second is wasted when trying to navigate across the two sides of the AV node. Then the current will hit the bundle of his and cause a septal activation. Then it will go across the left fascicle, then about the right fascicle. The reason being right fascicle has a higher refractory period, and then it goes by the Purkinje fibers, which are actually modified muscle fibers, and the current goes from inside to outside and causes the depolarization. And the repolarization current will be flowing from outside to inside and is responsible for the T wave. Now the problem in this particular patient that I'm going to show before you is an accessory bypass pathway. The way I've shown the red fiber, I want to highlight that it is bypassing the AV node. Remember, AV node is like a broken Indian road, and the red fiber that I've shown before you is like an express highway. So the current will preferentially tend to go across this express highway and will cause an early activation of the ventricles. The topic that I'm teaching you guys is called as pre-excitation syndrome, or is alternatively called as Wolff-Parkinson-White syndrome. The first and the foremost problem of this person is ventricles are getting excited earlier than normal. And when I say that, the query from a lot of doctors is that, sir, what is the problem with the ventricles are getting excited early? It should be good now. The point is, if you have an early excitation, then ventricles did not get sufficient time to relax. So they will not be properly filled with blood. If you cause an early activation, the ventricle will contract partially filled because it did not get time to properly get filled with blood. And because of this contraction of partially filled ventricle, there will be a decreased cardiac output. In this patient of Wolff-Parkinson-White syndrome, the red fiber that has been denoted or highlighted here is called as bundle of Kant. It bypasses the AV node. The bad news is pre-excitation syndrome causes a contraction of the ventricle, true, but it will be a premature contraction without getting filled with blood, or I can say the word early contraction. The message is these patients will be having recurrent syncopal attacks. The contraction of, or which is a premature contraction of a partially filled ventricle. I want you to focus on the statement that I've highlighted at least twice, because this is the crux of this discussion. In fact, two conditions that I'm going to explain to you in the next 10 minutes or so will mainly focus on this statement of mine. Premature contraction of partially filled ventricle, which explains the relatively less stroke volume, which explains the relatively low cardiac output of these patients. The reason why this person will come to me is that he says that while sitting on a chair, even from a very young age, he feels as if his heart is pounding in his chest. If he's a little educated, he might use the word palpitations. And for this, he had gone even to a psychiatrist who told him to take some anti-anxiety medication, but there is no relief. He says, sir, there have been instances when I was trying to maybe play with my friends. I'm not going to talk about sudden cardiac death in this case, guys. Sudden cardiac death, yes, can occur in this condition while playing football, no doubt about it. But what I'm saying is, he says, sir, when I was playing football with my friends, or when I was trying to do any kind of activity, something as simple as dancing at a marriage party, I became unconscious and my friends always make fun of me or say that I am physically weak and not able to match their stamina. If he gives me a family history of sudden cardiac death, it is all the way more important, because Wolff-Parkinson-White syndrome definitely has a genetic pattern, or has a very characteristic genetic pattern of inheritance. So family history of sudden cardiac death has also been discussed in HOCM. So I'm not saying that you need to put too much of importance to that statement, but over and above this, what you need to analyze in the question is, because he's talking about palpitations, recurrent syncopal attacks, it could be not a HOCM question, it could be Wolff-Parkinson-White, because when he gives you a history, there's a possibility that examiner knows the fact that you know about sudden cardiac death in a football game, so he might try to actually make you fall into the trap of answering it as HOCM or HCM per se, whereas the question will be that of Wolff-Parkinson-White syndrome. I will now explain to you how in the ECG will you analyze that this is Wolff-Parkinson-White syndrome. One of the important concepts that I'm now saying is that yes, the ventricles will get excited early, as you can see from the red fiber which is causing an early activation, but once the current will enter in the muscles, mark my words, once the current will enter in the muscles, then it will not spread by a Purkinje. If the current has to spread by the Purkinje system, it has to follow the normal pathway, the SA node, AV node, bundle of phase, then it enters into Purkinje. Now, what is happening in the heart of this patient is technically called as intermyocyte conduction, and the importance of knowing this intermyocyte conduction is that intermyocyte conduction will be slower than the Purkinje. Remember, the physiology guy would have always said fastest conduction fiber in the heart, Purkinje. Everything else is slower than Purkinje. Therefore, intermyocyte conduction, because it will be slower inside the ventricles, the current will be flowing relatively slower, so the Qrs complex duration will be affected in these patients because of using the word intermyocyte conduction is slower, so the Qrs complex will tend to become relatively broader in this condition. The message is, in these patients, because there is going to be a fast conduction via the SA node directly to the ventricles, therefore PR interval may be shorter. The reason for reduction in the PR interval is the fast conduction with respect to what I've shown in color red, but inside the ventricles per se, the current will spread relatively slow. I'm going to highlight this once again, guys, because most people say, sir, on one hand you're saying fast, on the other hand you're saying slow. So please appreciate the perspective. When I say bundle of Kant, it's going to cause an earlier activation of ventricles, but when it comes to ventricles per se, the current inside the ventricle muscle will be spreading relatively slower. So let's just make sense of this from the ECG perspective. What I have highlighted before you at the moment is perfectly normal. I'm just trying to make it a little more broader than what it normally is for me to be able to explain to you the various intervals and durations. You see the starting of the P to the starting of the Q wave is called as PR interval. Now I'm going to put a green point at this particular area. This is the isoelectric point and is called as the J point. The distance between the red point and the green point, the second red point and the green point is called as QRS complex. And if I join the two together, PR plus QRS complex, then it will become PJ interval. First we look at the mathematics behind it. PJ interval is a combo of PR plus QRS. That's the first message. Now let's look at what actually happens in these patients. Because he was complaining of palpitations. I've already told you the fact PR interval is always going to exhibit an inverse relation with heart rate. There are two reasons why I'm saying PR in this person is short. One, I said bundle of Kent will conduct very fast, so therefore PR is shorter. Second, tachycardia will contribute to short PR interval. So message number one for the ECG of this patient is short PR interval will always be noticed. I told you the duration, no, 120 to 200 milliseconds. In this case, it will be less than 120 milliseconds. The reason for short PR interval is first and primarily due to fast conduction, ultra fast conduction that occurs via Kent, and that is why this was misdiagnosed as a case of anxiety neurosis. The second thing is very important from the exam perspective because in this person's ECG, Q wave will not be seen. I have taught you the fact that Q wave occurs due to septal activation, but look at the path of the current in the heart of this guy. The current is going to bypass the AV node. It is not going to go in the bundle of phase. It is directly going in the ventricles. Now, since the current is directly going in the ventricles of the patient, as a result of it, there is a technical term used that is pre-excitation, and I will like to mention the fact that the Q wave in the ECG of this person will be absent. In which lead do you check for the Q wave? Remember in the starting I mentioned V5, V6. In this particular case, the Q wave is going to be characteristically absent. Now, let me just draw the normal Qrs complex before you. I just exaggerated the QR and the S. In this person's ECG, there is going to be no Q wave present. And when you look at the R wave, you will notice that there will be a slight change in the slope in the upswing of the R wave. I'll just zoom it in for your convenience. What I am saying is R wave in you and me will have a smooth upswing, but if you see in this particular case, there's a slight change in the slope, and that's the key word of this entire discussion. This is the reason why I'm discussing this topic with you. This is what is called as a delta wave, and is one of the classical features that is always asked for Wolff-Parkinson-White syndrome. In fact, when I started this topic, the ECG that I brought to your notice was, and now I hope it will make relatively more sense. You can notice the movement of the piece finishing. There's no Q, there's no PR interval per se. That can be visualized in this case. Immediately you are noticing there is an upswing of the R with a change in the slope of the R wave. This that is highlighted here is called as the delta wave. The learning for us is that whenever we want to read about a young guy having possibility of palpitations, syncopal attacks, and sudden cardiac death with respect to maybe his sibling, brother or sister, don't only think in terms of HOCM, keep your horizons broader, and it could be a question of Wolff-Parkinson-White syndrome also. And why that is important is if he will ask you the treatment here, the treatment will be different from that of HOCM. We are not going to deploy a ICD in this case. We are not going to go for myomectomy in this case. We are not going to give propranolol for this case. In fact, for this particular person, if I want him to be normal, I have to realize there are two conduction systems in the heart of this guy, the normal one, the abnormal one. If I destroy the abnormal one, if I do a radio frequency ablation, I will be able to cure this patient for once and for all. So when I focus on the aspects related to the ECG of this person, I have highlighted before you that the Qrs complex, I'm calling it Rs because there is no Q, will be relatively broader. Now why is it broad? One, this change in the slope will contribute to slight broadness. The second reason for the broadness here is intermyocyte conduction. Remember I said the concept of physiology. Intermyocyte conduction is slower than any other conduction fiber in the heart in a sense that Purkinje is the fastest one, so this has to be relatively slower. So when I say slower, it will be broad. And now mathematics comes, guys. Give me undivided attention on the board, please. I said the PR interval of this case will become relatively short. The Q will become absent and Rs will become relatively broad. So if I say mathematically the reduction of PR, listen to the words carefully, the reduction of PR is equal to the prolongation of QRS or slash RS complex. If PR is short, RS is broad, both mathematically equal, then the PJ interval will remain unchanged in this condition. One of the important diagnostic criteria for diagnosis of WPW is PJ interval is going to be perfectly normal. In fact, they can give you a ECG, they can give you a history based on this. So I would definitely like to rate this as one of the important topics that you are understanding today, that when it comes to WPW, there are two problems in the patient. The excitation occurs ventricle-wise earlier, but when it comes to ventricles firing by themselves, they might be relative delay, they might even be a bundle punch morphology coming up because there's an intermuscular conduction present in this guy. Now let us look at what will we do for management of this condition. So this is how he asked the MCQ. He wrote the word AP. AP means accessory pathway. See, there are two conduction systems in the heart of this guy, no? Normal one and the abnormal one. So the question said AP, accessory pathway, mediated tachycardia. And he said that this person is having a syncopal episode or neo-syncopal episode. What will be the management of this person? He has been referred to you from, let me say, psychiatry department. Heart rate is going up to, let me say, 150, and he's saying, sir, I just feel as if I'll die, and I'm having this findings of pre-syncope as well. I feel as if I'll become unconscious. That's the description. People will roll their finger like this to say that my head is spinning. Well, you secure an IV line and give a drug to this patient, which will force the current to actually now go via the normal circuit. See, procainamide is the emergency drug for this condition because it slows the conduction by bundle of Kent. If you put on the brakes in bundle of Kent, the current will have to go by the normal pathway. However, if he asks you what is the best drug for prevention of such episodes in future, then I will have to put this person on an oral medication that is flecainide. Please remember, in emergency scenario, it is procainamide. For prevention of episodes, it is flecainide. And over and above this, if he says what is the treatment of choice for this genetic condition, which can be autosomal dominant, then it is radio frequency ablation. I mean, I'm simply saying I'm going to fry up the abnormal electrical circuit, and therefore the current will be forced to go by the normal pathway and will cause normal lifestyle to develop in this patient. Most of the time, this question is asked to actually check for the treatment of choice because, as I've highlighted, in cardiomyopathies, it is implantable cardioverter defibrillator or cardiac transplantation if feasible, let me say for DCM. But in this case, the abnormal pathway can be burned, fried, those are casual terms that I'm using. The technical word is radiofrequency ablation. And just to see whether you've understood me or not, I'm going to draw this diagram once again of normal and abnormal circuit. And please be patient while I sketch before you and then tell me the difference between this diagram that I'm now making before you and the one that I made earlier. At the moment, so far so good. Septal activation, current goes to left vesicle, right vesicle. This is Purkinje, very fast reduction, and we can be having contraction of the myocardium because the current will be able to go via this electrical circuit. Everything is normal at the moment. Now I'm going to show a short circuit. The current is going to bypass the AV node once again. See, AV node is relatively slow conducting. AV node always exhibits what is called as AV nodal delay, which will be a delay of approximately 0.1 second. In our case, the current of the SA node will definitely be able to bypass this ultra slow conducting pathway. This is the express highway that I'm talking about, which will directly cause activation of bundle of hairs, will cause a septal activation, will cause the current to go to left vesicle, right vesicle, will utilize the Purkinje fiber. See, if you compare this diagram with the previous one for WPW, you will notice that in WPW, the conduction system of the heart Purkinje was not being utilized. But in the current sketch that I made before you, there is a very characteristic utilization of the normal conduction pathway. Agreed that there is a short circuit in the heart, but ultimately Purkinje is still being utilized. The condition that I'm discussing in this moment, and I'm very sure you would have guessed the answer by now, is called as Genome-Levine syndrome. Well, when it comes to Genome-Levine syndrome, will you be having a Q wave? Yes, because septal activation is occurring in this case. What will be the duration of Qrs complex in this condition? It will be normal or will be lesser, but can never be prolonged. In the previous case of WPW, why it was prolonged was because Purkinje was not being utilized, intravascular conduction was happening. No, now it makes more sense. But in contrast, this particular patient, he's going to utilize the normal conduction system, whatever God has given. So let's look at the problem again with this pre-excitation syndrome. I mean, this term itself results in first impression coming to a person's mind is, if you say early excitation, what is the problem? But as I explained, there would be a early contraction of a partially filled ventricle, so the cardiac output of these patients' stroke volume will anyway be lesser even while sitting on a chair. Forget about any kind of strenuous activity. So I have this individual who's today deliberately hiding the symptoms of palpitations and recurrent syncopal attacks. Why? Because he's applying for a government job. Let me say he's applied for sub-inspector job at Delhi Police, or let me say he wants to be a pilot, or any kind of job where physical fitness is required, even if he wants to be a commercial pilot. He is hiding this history of palpitations, recurrent syncopal attacks, and most of the time when a person applies for a government job, he has to declare the health of his family members. If you have ever applied for a medical officer job, you will notice they give you a performer. In that you have to actually fill up, health of brother, father, mother, sister, everybody. And if somebody, writes by himself that his brother or sister had died, the doctor of the medical board immediately knows that you need to be evaluated, the person needs to be evaluated because before he's selected for a government job. The message here is family history of sudden cardiac death was present in this person, but the patient of LGL is deliberately concealing his history. My capacity should be such that even if a person does not tell me the history, I should still be able to solve and analyze, is this person having some problem with his heart? I had told you, PR interval and Qrs complex together make PJ interval. In this particular case, because there is a short circuit happening in the heart, so the PR interval of this patient will be shorter. But the QRS duration will be normal because normal conduction system is being used. So what is going to happen to PJ, guys? PJ will be short. If you're listening to me carefully, you will notice in WPW PJ was normal, but now teaching you PJ is relatively lesser. Just for the sake of completion, I want you to remember, when it comes to short PR interval, you can declare a guy medically unfit or at least subjected to specialist evaluation. Why? Because when it comes to a person with a short PR interval, he could be having the short circuits in the heart which are causing an early excitation. Even if somebody is hiding the history, you can at least temporarily make a person medically unfit, especially in those jobs where physical stamina is required. Even if I say doctor's job, now if you're working in a COVID ward, you're working those shifts, a person has to be on his feet for all the time. If somebody is having this defect in his heart, he will not be able to handle the stress. The message here is, whenever you read about short PR interval, Q wave will be present, QRS duration will be normal, and the PG of this person is relatively short. It is suggestive of, and obviously we can do electrophysiological studies to confirm it, it is suggestive of Genome-Levine syndrome. Mostly in the exam, they ask you the comparison of the ECG findings between the two, so I will do that activity too, but if you can just write those ECG findings in comparison, majority of your work is done. Now let us look at what is going to be the treatment for this condition. In the MCQ for LGR, he will write AP pathway, accessory pathway, mediated tachycardia. In those circumstances, you will still be answering IV procainamide. Today, I brought you procainamide as a drug of choice for two cardiac conditions which are having a pre-excitation syndrome, WPW and LGR. If he says, how would you prevent such episodes in future? Because every time he thinks that he's having a panic attack, he's rushing to a psychiatrist. The psychiatrist is loading up with benzodiazepines and other drugs, whereas this guy is not responding to that medication. So to prevent such medication, you will be recommending oral flecainide for these patients, but the day he will miss the medication, again the manifestations will appear. So I need to find a permanent cure, and the permanent cure for this person of Genome-Levine syndrome would be to undertake a RFA, a radiofrequency ablation. So 2 times radiofrequency ablation is the treatment of choice, WPW and Genome-Levine syndrome. Just to see whether you've understood me or not, I'm just going to give you a quick overview. We'll try to analyze the two diseases under, let me say, 30 seconds to 45 minutes. WPW versus LGL. One of the highlights of WPW is presence of bundle of Kent. While I'm writing it, guys, please tell me if you have knowledge of basic anatomy / embryology. What is the abnormal pathway in LGL called as? When it comes to Genome-Levine syndrome, I also do abnormal pathway which was shown in color green, and this is the one that is going to be definitely causing problems for the patient. So the word used to describe this is called as James fibers. So sometimes they might even use Mahim fibers. In fact, there are two different ones, but I just want you to remember that bundle of Kent is specific for WPW and James fiber and Mahim fibers are specific for LGL. Then WPW will always be having a very characteristic delta wave present, and most importantly, when it comes to the RS complex of these patients, it will be relatively broad. I'm going to highlight this fact. Whenever there's going to be antigrade, that is forward conduction by the short circuit, there's going to be broad RS complex. There's going to be no delta wave. On this case, it is only the PR that is short and PJ that will be short. But on the left hand side, the PJ interval will turn out to be normal. Why? Because mathematics, PR was short, RS was broad, both were balancing each other. For both of these conditions, we are going to be using procainamide. Now maybe I've reached that 1 minute barrier that I was trying to say, but because I have to write and speak, so that is why. Otherwise, your thought process has to be crystal clear. This is guys the emergency drug to be used. If they both are to be answered carefully, no, otherwise people get confused, sir, what should I answer if it is an emergency situation? Like he says, so-called panic attack. And he's saying, sir, I am feeling so dizzy, I'll just fall down, or actually fell down a flight of stairs. Luckily, there's a pump on the forehead, no severe CNS bleeding. I don't want him to fall again when he goes out of my clinic again. So to prevent this from happening, it is flickenite, and then I'll be subjecting this patient to radio frequency ablation. And while I'm writing this data down before you guys, I just want to share a personal experience. I was once taking a class in Lucknow. Brilliant guys from KGMC, and one doctor walked up to me after the class, a face-to-face one, and he told me that from a very young age, when he was preparing for his PMT, he has been complaining of palpitations and different psychotic attacks. He was the only child of doctor parents, right? Parents were also doctor, and he told me that he has been to various psychiatrists, etc., but there is no improvement. So I casually told him, let's get a easy done. And surprisingly, I am telling you this is a person from a doctor's family, he himself a doctor, right? I mean, finally, going on to intern, attending a medicine class. He has been suffering from palpitations for that long, and he was neglecting his health. Most of us doctors neglect our health and do not see a doctor or do not go, and we think it's kind of a stigma. No, everything is going fine. And the ECG of this guy showed very characteristic delta waves. Now the ECG showed delta waves, so obviously I had to suggest him to go for radio frequency ablation. And after that, obviously his episodes resolved, and he cleared a PG entrance exam. He's actually completed by this time. I think he would have completed his MD medicine also. But I just shared this experience to say the fact that lots of time doctors are aware of this condition, but what I'm saying is somebody was suffering from it, and well, he never got himself evaluated. So lots of time we doctors tend to neglect our health. That's one point I wanted to say. And this is again an important topic, guys. I mean, examiners love to ask regarding delta waves, and sometimes they might change the question also by changing the language of the question. Now just look at the minor point that I'm going to say. It will look minor at the moment, but in the exam might be, changing the entire domain. He might say delta wave in EEG of the patient. Now that's going to change the entire domain, no? Because I was talking about delta wave per se with respect to ECG, whereas delta wave in EEG is found in NREM stage 3. If you go through the EEG and the epilepsy lecture, I have definitely talked about it, so I said, okay, it's a minor aspect at the moment for you, but do read the question because sometimes people tend to mess up on this. Delta wave in EEG is NREM stage 3. Let's look at one more such minor finding which is to be remembered. The question asked in one of the NEET exams was pseudo P pulmonale is found in. A lot of guys casually read and thought it is P pulmonale, pseudo P pulmonale. If you go through the electrolyte imbalance part, if you go through the ECG and hyperkalemia with hypokalemia changes, then I have highlighted this statement of mine. Pseudo P pulmonale as a feature of hypokalemia basically means that the P wave vertical height will be more than 2.5 millimeter. In the absence of pulmonary artery hypertension, I repeat my statement once again, guys. The meaning of this word would be that there is no pulmonary artery hypertension and still the vertical height is increased. That is why the word pseudo is used. So these are two accessory issues that I wanted to remember. And the objective of the current part of the discussion was to sensitize you to conditions which would be having a short PR interval. At the moment, we've discussed two of them, both require radio frequency ablation, WPW and LGL. The next component of the ECG that I'm going to explain to you would be aspects related to the prolonged PR interval. And here we shall be talking about the various types of heart blocks, that is first degree, second degree, third degree. So I will be drawing a couple of line diagrams here where I'll try to explain how you can easily differentiate in a limited time frame between these various varieties of heart blocks. The problem is that the person will be having effort intolerance, and there could be pre-syncopal attacks, there could be even syncope developing in the patient. Whenever you're going to read this word, first degree heart block, then the problem in the patient is not inside the SA node, the problem is neither inside the AV node, neither in the bundle of his. The problem is in between the connection. Like in this case, what I'm showing in the form of these red dots can be taken as a representation of Ashkoff nodules or non-charismatic granulomas or sarcoidosis, so they will slow down the conduction. See, AV node is anyway slowly conducting as I highlighted. There is always a AV node delay of 0.1 second when the current goes across the two sides of the AV node and then hits the bundle of his, and then it will utilize the Purkinje circuit and will cause ventricular depolarization. I have just put some pointers here to say that the exact damage in first degree heart block is between point number A and point number B, that is the connection between the SA node and the AV node per se. When it comes to the firing of the bundle of phase, when it comes to the septal activation, it's perfectly fine. Now we will understand why is it happening. The usual cause for it, or rather a common cause for it, this happens to be physiological. But because physiological is something that is unlikely to be asked in the exam, so I'll talk about first the traditional ones. As I highlighted, you could be having rheumatic heart disease. In fact, if you listen to the discussion of rheumatic fever, in the minor criteria, I specifically pointed out the word prolonged PR interval. Why? Because when the conduction speed will become slower, there would be a bradycardia, and therefore, as I explained, heart rate and PR have an inverse relation. The next example is sarcoidosis. Even in the topic of sarcoidosis, I've highlighted this fact, and cardiovascular mortality is anyway a big problem in all patients having rheumatological disorders. Then can be iron deposition. The disease that I'm mentioning at the moment is hemochromatosis. It can be either of the primary and the secondary variety. This will cause a stiff heart. So the problem in hemochromatosis is one, it can cause a cardiomyopathy. Second, it can hamper the conduction system in the heart. The next disease is more common in the southern part of India. And look at the longish name that I'm going to write before you. The disease is referred as Endomyocardial Fibroblastosis. When you just focus on the word, you see fibroblastosis is telling you that there is going to be fibrosis in the deeper layers of the heart. Mainly the conduction system is going to be hampered. As a result of it, the conduction speed can be affected. Now, if they ask you what is overall the number one cause of it, then as I highlighted, it would be answered as physiological. It will mainly be athletes. I can give an example of this athlete being a high performance athlete rather. He's a marathon runner. You see, marathon runner is going to complete 42 kilometers in limited number of hours. That requires a substantial amount of stamina. So the heart always gets into oxygen conservation mode. People who are marathon runners or do these endurance sports per se, they tend to have a high wiggle tone, and this high wiggle tone explains the first degree heart block to be physiologically present. In those circumstances, obviously nothing is to be done. But let us now actually look at how the ECG of this can be given to you. Let us assume while you are sitting comfortably and you are listening to me with your headphones on, you are listening to this lecture. Because you're sitting comfortably, let us assume that your PR interval at the moment is 120 milliseconds. I've already given you the range. 120 to 200 milliseconds is the range for any one of us. That's going to be about 3 to 5 small squares. Now, if I request you to, just get up and from your chair and do a couple of sit-ups. You see, all of your young people, you can definitely do 4, 5, 6 sit-ups. I just requested you to do only 5. When you will do sit-ups, then the point is your heart will have to work more, so your heart rate will increase. And when your heart rate will increase, then the PR interval will become relatively lesser. So my point is that our PR interval is not constant; it tends to change with the heart rate. I've already explained this concept earlier by simply saying heart rate is inversely related to PR interval. There I just said that any kind of physical activity that you do, like sit-ups, push-ups, planks, whatever, the PR interval will become relatively lesser. So in you and me, the PR interval will vary with exercise. But in patients of first-degree heart block, this this variation will not be there. The PR interval will always remain prolonged. It can be even more than the normal limit of 200 milliseconds. Like what I'm saying is that in a normal person, the PR interval will change with physical activity. If there's going to be vagal stimulation, the PR interval will become prolonged. If there's going to be sympathetic stimulation, PR interval will become shorter. PR interval in normal person is always variable. This variability will be lost because of the reasons that I explained to you in the previous slide, ranging from granulomas to iron deposition to fibrosis developing in a heart. So people with first degree heart block will mainly come to you with the complaints that I cannot run as fast as I used to do earlier, or he might compare himself with his wife or with his children or anybody else, especially if the person would like to do any kind of minimal physical activity, not only about running, it could be something like just climbing a flight of stairs. So exercise intolerance and fatigue is the usual reason, and these are relatively initially very non-specific complaints, so you might even miss the diagnosis, but subsequently because the complaints are persistent, you decided to get a ECG done. In this person, you will always notice that the PR interval will always be in excess of normal. It will always be more than 200 milliseconds and will not change with exercise. That's the point. It will not vary with exercise like it can happen in you and me. Now the point is, if pacemaker will malfunction, we can change it. But obviously, suppose the correction is hampered, then you can't do much for these patients. So there's definitely no treatment. The word is no treatment for first degree heart block patients. Yeah, in some books, I'm just mentioning it offhand. In some books, it might be mentioned that oral atropine can be used in these patients. That's just an offhand remark because atropine can slightly increase the reduction, reduce the symptoms, but then there's side effects also. And if you give atropine or oral on a regular basis, it will cause a lot of side effects also. So we have to obviously balance between the benefit versus the loss side. In this condition, all I can say to the patient is that you should not do any strenuous activity, weight-bearing activity, or trying to climb stairs with a backpack on your back. Maybe you can climb stairs slowly, but don't try to put too much of stress because if he ends up with syncope, he can end up with a head injury as well. So as such, first degree heart block will not cause an immediate threat of life. Yes, the patient will require some modification in his lifestyle. It is that, he's not supposed to carry a heavy weight, he's not supposed to carry heavy grocery bags, he's not supposed to carry a backpack of 10-20 kg on his back. Like normally when we are like shifting an apartment, we people are like buying grocery from the grocery store, we might be carrying heavy bags. This guy will definitely have some issues with that. So just I would say that restriction of strenuous physical activity is what is recommended for these patients with first degree heart block. And now we will be comparing this with second degree heart block, which is the one that is usually asked in the exam. There are two variants of it. One is going to be Mobert's 1 heart block, the second one is Mobert's 2 heart block. So I'll hand draw the ECG before you to actually explain how the manifestations in these patients will develop. Please remember that lots of time in the multiple choice question, instead of writing the word the traditional Mobert's 1, they would love to ask this, I would say longish name, that is the technical name, that is Ventricle phenomenon as well. And let's now understand how this Ventricle phenomenon will evolve in the patient. I mean, where is the problem? So I have once again highlighted the SA node. It is going to conduct into the AV node, the both sides of the AV node, the fast flow pathway will ultimately cause septal activation, bundle of phase is going to get activated. In these patients, the problem is not in the SA node, the problem is not in the conduction pathway up to the AV node. Yeah, there is definitely a problem because AV node is conducting even slower than what it normally does. But at the same time, the way I've drawn the diagram before you, I wanted to highlight that the exact site of lesion in these patients is between point number B to C, and that is inside the AV node. So lots of time they might use the word intranodal to describe Mobert's 1 heart block. Now let us understand how the ECG of this person will evolve. When you will scan the ECG from left to right, you will notice a progressive increase in the PR interval of this patient. Please be patient while I just hand draw the same before you, because the easiest for me is to show you a ECG, but then the point is lots of time you might miss up a couple of facts. So let's just try to hand draw this so that we can get a better orientation. You see, whenever you will see the ECG of this person, you will always see an area where actually after the P wave, you will be noticing there is no Qrs complex. You definitely can differentiate between the T wave and the P wave based on the height criteria. I've explained to you that the height of the T wave in the limb lead says 5 mm, in P wave it is 2.5 millimeters, or with the height you can differentiate. But now just putting a vertical arrow here to say that this is the site where I expected the Qrs complex to be present, but it is sadly not present. This is the time the patient might actually put his own hand on his pulse, and the patient might say, sir, my pulse has disappeared. I mean, this person, he is putting his own fingers on his pulse and showing you, sir, see, my pulse has disappeared, and I felt as if my head was going round and round in circles, and I felt I might become unconscious, because this is the time when the ventricles did not fire. If the ventricles are not going to fire, then the cardiac output will definitely be hampered in the patient at that particular point of time, and then the rhythm will be reset. You will notice once again, the PR interval of the patient will definitely be present in the next beat. Serially, again, the same pattern will evolve. Again, the PR interval of the patient will start progressively increasing. So if I just put pointers there, I wanted to say that suppose the PR interval initially was 160. Then it jumped up to, let me say, 190 milliseconds. Then it jumped up dramatically to, let me say, 200 or let me say 210 milliseconds. I'm just putting in some random values here to say that there is a progressive increase in the PR interval. And let's zoom it in for your convenience. You definitely can notice that the number of squares between the P wave and the starting of the Q wave. Remember, PR interval is not up to the R wave, it is the starting of the Q wave. The PR interval is definitely showing an increment. And then this pattern is again getting replicated. You again can see 160, it will again become 190, and the subsequent one I can also draw before you, saying that now it would be 210 milliseconds, and this is going to go on and on. Now in the exam, your query would be that, sir, if I count so many times, there's a distinct possibility that I might forget. Like suppose I'll put it on myself. Suppose in the exam, in a stressful situation, I'm counting the PR interval the first time, the second time, and the third time. There's a possibility that when I'm counting the PR interval a third time, I might forget what was the value the first time. So what he says is that the movement you identify the missed beat, listen to this part carefully. He says movement you identify the missed beat, which will usually be given in the exam in the form of a vertical black arrow. This highlights the fact that at this point of time, Qrs complex should have been present, but is sadly missing in this case. All you need to do then is, listen to the words carefully, all you need to do if you identify the missed beat, either by the vertical arrow given by the examiner, suppose it does not even give it, you can at least identify the P wave now, and after the P wave there's no Qrs complex, you just need to look at the PR interval after and then before, and you will notice the fact that the PR PR interval after and before will always be unequal in Mobitz 1 heart block. I want to repeat this again, guys. If you want to get this question right in under 1 minute time frame, all you need to do is look at the PR interval after and before, and you would definitely be more confident in evaluating Mobitz 1 heart block. In fact, when I'm going to describe or hand draw the ECG Mobitz 2, you will find this will become even more easier. Now, please remember that you can definitely count the conventional way of counting the PR interval the first time, second time, third time, fourth time onwards, but there's a possibility that it might skip out of the mind. So to minimize the errors, he says count the PR interval only 2 times. And when I describe this for Mobitz 2 heart block, you will notice that the things will become relatively even more easier. So when it comes to Mobitz 2, let me first try to explain where is going to be the lesion present. So once again, we're going to just put some pointers here. This is SA node, AV node, then the bundle of fissure. The pointers are highlighting the conduction from the SA node to the AV node, inside the AV node, and then there is a septal activation with respect to the bundle of fissure. Now, what I want you to understand is that in people with Mobitz 2 heart block, the problem is below the AV node. Mark my words there, the problem is below the AV node. It is actually the lesion is in the bundle of fissure. Therefore, the technical term that might be used lots of time to describe Mobitz 2 heart block is infranodal heart block. In fact, earlier, though I had said it, I had not written it. When it comes to Mobitz 1 heart block, because it is inside the AV node, I repeat the fact, it's inside the AV node, so he will say the word intranodal. You see, again, he's trying to play around with English words there. It is intranodal versus infranodal, because obviously it's inferiorly located. Now, the point is, PR interval is the distance between point number A to point number C. Please be clear, PR interval does not mean conduction from SA node to AV node. It is SA node to exit from the AV node. So PR interval is point number A to point number C, and the damage is at point number D in this diagram. So therefore, PR interval is not going to change. There's going to be sudden drop beat, yes, but why PR interval is not changing is because damage is not in the area per se which represents the PR interval in the ECG. The damage is below the area which is beyond the PR interval representation. So per se, you are going to get an ECG which will be having 160, 160, 160, 160, and then a drop beat. In this particular hand drawn sketch, what I will try to do is, I will try to make it as symmetrical as possible, the PR interval. Like I have tried to make it almost the same duration. This is 160, 160, 160. Can be continuing for 4-5 beats. Perfectly normal till now. I mean, so far so good. No problems. But then you will notice that there is a P wave, and then you're waiting. There is no Qrs complex. And if he's kind enough for you, then he might actually give you vertical black arrow highlighting the area of the misbeat. And even at this point, the patient might volunteer information. The doctor has started feeling dizzy again. In between, because the bundle of fissure is exhibiting a very erratic behavior. Sometimes he conducts, but sometimes he's not conducting. So because of this, there would be sudden drop beat occurring in this patient. And then once again, the rhythm will be reset. You will notice that if you look at the PR interval after the missed beat, it would be 160. And now there is absolutely no problem going on till the pattern reoccurs. It is not necessary that it will occur after 3 beats only. It could be 4, it could be 5. It might be continuously happening like normal sinus rhythm for 3-4 minutes. And then there could be a sudden drop in the conduction in these patients. And therefore, what you need to do in the exam is very simple. All you need to identify is the area of the missed beat, and then look at the PR interval after, then look at the PR interval before. You can very well notice that in Mobitz 2 heart block, the PR interval before and after is always going to be equal. So guys, the main message from this slide is, and I would be really happy if you can just hand draw this diagrammatic representation by yourself at least once, so that you get a hang of the stuff. When it comes to Mobitz 1, it is going to be a scenario of prolongation of PR interval, drop beats, then it's going to be again a prolongation. So all you need to do is calculate the PR interval 2 times, before and after or before, that does not matter. Point is, in Mobitz 1, it's going to be unequal PR interval. In Mobitz 2, it's always going to be equal PR interval. That is how you can easily identify. And I want to also highlight the fact, and I'll prove it to you subsequently, that Mobitz 2 is more dangerous than Mobitz 1. Why? Because Mobitz 2 occurs very suddenly, whereas Mobitz 1 occurs gradually, so the heart gets used to it. But in Mobitz 2, which is going to be suddenly developing manifestation, in fact, there can even be sudden death. I'll even prove it better on my subsequent slide where you'll get more leverage of more space so that I can explain this to you. But at the moment, I want you to remember, I have taught you already, sudden death in MI is due to ventricular fibrillation. But if he says which bradyarrhythmia causes sudden death in MI, the answer is the topic that I've just explained to you, Mobitz 2 heart block. I will repeat this again, guys. Tachyarrhythmia in myocardial infarction that occurs as early as the infarction has occurred within the first few hours only, preferably might occur in the very first hour only, and the person might die also. That's going to be a scenario of ventricular fibrillation, tachyarrhythmia. But when he talks about specifically bradyarrhythmia, your answer should be given as Mobitz 2 heart block. That is also called as infranodal heart block. And this entire slide, I would rate that as the most important slide from the bradyarrhythmias component, because most of the people, they tend to get tired counting the PR intervals. So I've just given you a hack which will definitely work almost every time. That is, just look at the PR interval 2 times before and after, and you will have a fair amount of idea. In fact, practice this in the subsequent questions given, and you will feel more confident about it. Now I shall be explaining to you regarding third-degree heart block in a patient. So let us first study that where is going to be the lesion present in this person, and then compare the ECG of this person with respect to the second-degree and first-degree heart block. The main problem in third-degree heart block will be problem of the AV node. Now I want you to listen to this part very carefully, because when I start talking about damage to the AV node and no conduction by the AV node, the usual query that I get from most of the students is that, sir, you thought that the damage in the AV node is also present in Mobitz 1 heart block. Remember, in Mobitz 1 heart block, I had said the word intranodal. I'll just go back to my previous slide. You see, you can also see that in Mobitz 1, the damage has been shown precisely in this area, that is the AV node person. So what is the difference? I want to highlight that when it comes to person suffering from Mobitz 1 heart block, it is relatively a slow conduction. Please listen to this part very carefully, otherwise we miss out on the main gist of the discussion. When it comes to Mobitz 1 heart block, it's always going to rather be because of the slow conduction. But when it comes to the current diagram, I have used the word no conduction. So that fundamental difference should be remembered. And the importance of knowing this information now is that SA node will not be able to control the ventricles. SA node will definitely be able to control the atria per se, and the firing of the atria will occur. The atrial rate will be approximately 100 beats per minute. No issues with that. But yours and mine, per se, the ventricles are controlled by SA node, but in this case, who's going to control the ventricles? Bundle of fissure. You see, whenever a pacemaker is malfunctioning, the pacemaker below it will take over the function. So in a person of third-degree heart block, it is rather ventricular rate being controlled by the bundle of fissure, as a result of which the ventricular rate will be only 40 per minute. Now, if you look at the mathematical association here, atria are beating about 2.5 times faster as compared to the ventricular rate. So one reason why these patients will be having syncopal episodes is EV dissociation. I have talked about EV dissociation with respect to tachyarrhythmias also. That is going to be ventricular tachycardia. You will read about this in the subsequent part of the discussion, that is SCG and arrhythmias part 2. But I want you to remember that EV dissociation as a word is read 2 times primarily by you. One in the topic of bradyarrhythmias right now, and second will come in the tachyarrhythmias component subsequently. Bradyarrhythmias is third degree heart block and tachyarrhythmias is ventricular tachycardia. The meaning of the word EV dissociation would simply mean that there is lack of coordination. You see, I have explained that atria contribute 30% of filling of the ventricles. If there's going to be lack of coordination, then the filling of the ventricles will definitely be hampered, and if input is lesser, output will obviously be lesser. Adding insult to the injury will be bradycardia. You see, there are two reasons where the cardiac output in third degree heart block is low. One of the reasons for low cardiac output is EV dissociation, and the second component is obviously what is written here, but still I need to put it for record purposes, bradycardia. I mean, heart rate of 40. You see, while you're sitting comfortably on your couch and listening to me with your headphones on, your heart rate, even when you're sitting comfortably, will definitely be more than 60. It would be something in the range of about 60 to 100. In this guy, the maximum heart rate possible is only 40 per minute. So most of these patients, especially when they change their position from supine to standing, or let me say this person went to the washroom. It could be an Indian kind of a toilet or a Western kind of a toilet. When the person suddenly stood up, there was a syncopal episode developing in this person. So most of these patients will be having postural hypotension developing. Now, obviously, patient does not know about postural hypotension component. So for the patient per se, he will just, or the family members will tell you that there have been not one but multiple such syncopal attacks in this person. The message is recurrent syncopal attacks can occur in diabetic neuropathy patients as well. But today we're talking about a bradyarrhythmia, which is directly decreasing the heart rate, contributing to lack of coordination between the upper chambers, that is the atria and the ventricles. And as I highlighted, atria contribute 30% of filling of the blood of the ventricle. So 30% BP value is anyway lost since the atrial contribution is not there. This is also going to contribute to development of super large A wave. That super large A wave would be called as Canon A wave. Canon A wave is different from large A wave. I can call Canon as super large A wave as well. Now we will focus on the ECG component of this person. I'll also mention a pediatric important cause for this condition too. You see, the main agenda that you need to understand with respect to this condition is that the number of P waves and the number of QRS complexes, they always match in you and me. I mean, you check out any ECG strip of a normal person. If there's going to be a P wave, then there's going to be a QRS complex, that is normal sinus rhythm. So number of P waves will always be equal to the number of the R waves per se of the QRS complexes. In this person, the ECG tracing will come like this. You will get a P, then maybe again a P. You expected after a P a QRS complex? No, it's going to be again a P. Why? Because atria are firing at a faster rate as compared to the ventricular rate, and then you're waiting for the ventricular contraction to occur. So there might be a prolonged PR interval followed by a relatively broad QRS complex. Now, why it is a broad QRS complex in this case is because the control is via the bundle of His. The control is not via the SA nodes. The conduction speed of bundle of His will be relatively slower. You can then notice a T wave coming up, then after P again another P coming up. Then I'm waiting for the QRS